Thank you to the Pan American Society for Clinical Virology for this recognition and for the opportunity to talk to you today. I titled my talk Role of Clinical Virologist and a multidisciplinary collaboration to improve patient outcomes in recognition for all the work that you do. The work that you have done has improved the care of many patients with viral diseases in terms of providing tools for risk assessment, rapid and sensitive diagnosis, guide for treatment and prevention, as well as predictors for eventual outcome. My field is in the area of transplant infectious diseases, and there is no virus bigger than CMV in the field. CMV is a herpes virus that remains latent after primary infection, but if it is given an opportunity to reactivate, such as during periods of immunosuppression related to transplantation, CMV can cause organ invasive diseases in the form of pneumonia, gastrointestinal disease, as well as encephalitis, among other things. Prevention is key in improving the outcomes of our patients, and there are two approaches in the form of either antiviral prophylaxis or preemptive antiviral therapy. The strategy of preemptive treatment has relied fully on advances in clinical virology diagnostics. In this approach, we monitor our patients with weekly CMV PCR testing, and as soon as they reach a certain threshold, antiviral therapy is started in order to prevent infection from progression into clinical disease. In a clinical trial that we performed comparing antiviral prophylaxis with a laboratory-guided preemptive antiviral therapy, we demonstrated that preemptive treatment is associated with a significant reduction in CMV disease at 1 year when compared to antiviral prophylaxis. The bigger question, however, is what is the clinically relevant viral load threshold? And this is a remake of a slide that I presented 20 years ago entitled Not All CMV PCR Tests Are Created Equal, because we had observed that viral load values reported by different assays as well as using different samples are not interchangeable. We have done studies to demonstrate that the most important factor in viral load variability has been the lack of standard calibrator. The WHO had since developed a WHO international standard to which we calibrate different assays. And as shown in this figure, there is improved harmonization in viral load reporting. However, there remains clinically important assay-specific differences in terms of time to CMV detection, time to CMV clearance, as well as the viral loads are not directly interchangeable. Accordingly, transplantation societies have advised their providers that CMV PCR assays are not directly interchangeable and that they should only be using one specific assay in guiding and monitoring every patient. Studies that we also conducted over 20 years ago now have demonstrated the really nice decline in viral load in blood compartments as soon as we start antiviral therapy. During the time we were using intravenous ganciclovir, and we were giving it for a duration of 2 weeks. And what we have observed was patients who remain to have viral load at the time that we stop antiviral treatment, as indicated by the red circle in the slide, they're more likely to develop relapse as soon as you stop treatment. And this was repeated again in a bigger study, which demonstrated that the viral load suppression at the end of treatment is a marker of CMV disease resolution. Accordingly, transplant societies have issued guidance to providers stating that treatment of CMV infection and disease should be continued until replication of CMV is no longer detected by CMV nucleic acid testing. I'd like to end by giving a few words on COVID-19 and recognizing all the work that you have done in ensuring that we have rapid diagnostic tests for this pandemic. In addition to rapid diagnosis, viral load has also been used as a surrogate for clinical efficacy, as shown in this clinical trial that compared monoclonal antibody against placebo for the prevention of hospitalization. And as you could see here, there is a more rapid decline in viral load in patients who receive monoclonal antibody treatment. While the clinical outcomes was not apparent in this clinical trial, the FDA had issued emergency use authorization for the treatment of patients who are considered high risk if they have mild to moderate disease. We had taken advantage of this availability of these monoclonal antibody products and performed studies in our institution to demonstrate that indeed the use of monoclonal antibodies in patients with mild to moderate disease resulted in reduction in all-cause hospitalization, reduction in severe disease, reduction in intensive care unit admission, as well as reduction in overall mortality. With that, I'd like to end by thanking the clinical virology community once again for all the work that you have done and in collaborating with clinical scientists like me in improving the care of our patients. Thank you so much, and I hope you have a great meeting.